Good afternoon, everyone, dear colleagues. Maybe it's good morning, it depends when you live, where do you live, in which country. On behalf of Serbian Society for Cardiovascular Surgery, I will be moderating this webinar. My name is Igor Končar. I'm vascular surgeon from Belgrade, from Serbian Clinical Center. Serbian Society for Cardiovascular Surgery is celebrating this year 20 years of since its first meeting, and we are trying to do our best to organize as much as possible events to connect cardiovascular surgeons, anesthesiologists, and also to educate young trainees and young surgeons. This is, let's say, first of its own regional webinar that is connecting several countries in our region, but also due to one of our special guests, we are connected with another big country at a distance from us. We are trying to connect Serbia, Bulgaria, Albania, Kosovo, Bosnia, Montenegro, Croatia, Bosnia and Herzegovina, but also we have a guest from Brazil. This webinar will consist in two parts. In first part, we will have our distinguished guests, our speakers, our experts in treatment of chronic venous diseases. And in the second part, we will have short interviews and reports from our colleagues from our regional neighborhoods in our region. As a guest speakers today, we have Professor Sorin Olariu, vascular surgeon from Timișoara. He is president of Romanian Society of Phlebology. Bună dimineața. We have another speaker, Professor Veselin Petrov, vascular surgeon from Bulgaria, from Varna. Dobry den, Professor Petrov. We have Professor Marcio Steinbruch, vascular surgeon from Sao Paulo. He is member of Brazilian Society of Angiology and Vascular Surgery. Bom dia. And we have Professor Dragan Milic, president of the Serbian Society of Phlebology and director of the Clinic for Cardiovascular and Transplant Surgery in Clinical Center Niš. Dobar dan. These four experts will tell us their experience and their knowledge about chronic venous disease. And after that, we will have our guest from region that I will introduce later on. Before and since our first speaker, Professor Olariu, is sharing his screen, I would like to ask our technicians to give you first question. We would like to know, what do you think about treatment of chronic venous disease at the beginning of this webinar? And so please, once you see the wizard in your screen, answer this question. And since we are waiting for Professor Olariu to share his screen, and he will start later on his first talk. This event, this webinar, is accredited by European Association for Continuing Medical Education with 1 point. Okay, Professor Olariu, please, we are eager to hear your talk. Thank you very much.
Okay. Thank you for inviting me to this webinar. It's an honor for me to speak on this webinar, and my speak will be about diosmina in the complex treatment of chronic venous disease. I don't have a conflict of interest. About terminology, chronic venous disorder is the full spectrum of morphological and functional abnormalities of the venous system. Chronic venous disease is any long-term morphological and functional abnormality of venous system manifested by symptoms and or signs indicating the need for investigation or treatment. And about chronic venous insufficiency, it's stages from C3 to C6 of chronic venous disease. About incidence of disease, worldwide is until 30% in women and 20% in men. In Europe, about 24–50% in general population. In Romania, 32%. It depends of the studies. The prevalence of chronic venous disease increase with age. More than 50% of adult population have this disease. Almost half of them have visible varicose vein. And unfortunately, chronic venous disease affects younger and younger people. You can see the classification, it's well known. And this disease is a progressive disease with a complex treatment, and this treatment address various evolutionary stages. About type of treatments, we have minimally invasive, conservative, and drugs. About modern endovascular procedures in chronic venous disease, we have thermal and non-thermal. About thermal is endovenous laser, radiofrequency, steam ablation, vena seal, glue, MOCA, mechanochemical procedures, ultrasound-guided foam sclerotherapy, and cryostripping. Some words about each of these procedures endoluminal. In endovenous laser, benefits are because it's safe and effective, non-invasiveness, no general anesthesia, minimal pain, it's an ambulatory method, fast recovery, and very good cosmetic results. About disadvantages, bruising, hematoma, phlebitis, induration, but or minor disadvantages. About radiofrequency, or the same benefits and disadvantages, but the catheter is thicker than laser fiber and it's harder to insert. About steam, steam is the ablation with steam at temperature of maximal 120 degrees, but the success is the same as endovenous laser. Glue, it's a very new procedure, does not require anesthesia, and elastic stockings is an outpatient operation. It's lunchtime surgery, so-called. The glue produce a granulomatous reaction of foreign body with inflammation, could be a big disadvantages. About MOCA, mechanochemical procedure, it's limited for one saphenous vein in 24 period because of those limitation of sclerosing agents. Ultrasound-guided foam sclerotherapy, it's a good, but occlusion rate was lower 25 compared to the other groups. About cryostripping, it's a very good procedure. It's a modern type of stripping. Advantages, it's minimally invasive, respect the principle of venous surgery, and compared with endoluminal methods, avoid thermal lesion, do not require intumescent, remove disease vein, so no recurrence. Correct crossectomy, cosmetic results are very, very good. It's applicable for day surgery. About recommendation of European College of Phlebology, For the great saphenous and short saphenous reflux, class 1, it's laser and radiofrequency, and is preferred to surgery or foam. For short saphenous reflux, also laser and radiofrequency are preferred, and for symptomatic incompetence of accessory great saphenous vein, laser and radio are preferred. About steam, the class is 2, MOCA 2, glue is also class 2. Surgery remains important, and we cannot exclude surgery from complex treatment of chronic venous disease. It's class 1. The tributary, if they not to be treated, must to be in the same session. About diosmina and his role in the treatment, complex treatment of chronic venous disease. Diosmina is a member of flavonoid family, is an oral phlebotropic drug. Diosmina inducing venous constriction, increasing vascular resistance and reducing vascular permeability. Diosmina is presented in several dosage, and the products are indicated for improvement of symptoms of veno-lymphatic insufficiency. And it's good for complement treatment of capillary fragility. Also, it's used in acute hemorrhoids. Dosage is 1 tablet daily, and for hemorrhoids, it's 2-3 tablets daily. Some study about the effect of very short, I will present, comparative study between group with diosmina and group B with diosmina, flavonoid fraction, and hesperidine. We can see that heaviness in both group decrease the same. It's the same decreasing. About patient choice, is in favor of diosmina because it's single dose. Other study, Maruzinski, also the architecture, it's with 2 groups, group A with highly purified diosmina, and group B, macronized diosmina and hesperidine. About control was at 7 days, 14, 21, 28. About heaviness and pain, both groups have the same efficacy. Similar studies show that in patients with chronic venous insufficiency, treatment with 600 milligrams of diosmina brought significant improvement in quality of life and relief of symptoms. You can see here about heavy leaks, edema, paresthesia, nighttime cramps, restlessness, pruritus, or disappear. About quality of life after treatment, you can see it's a big difference. About our experience in our clinic have tradition in phlebology, and from our clinic start the Romanian Society of Phlebology. We use diosmin, and we use in therapeutic context. With other surgical method or compressive therapy, phlebotomic is very important. We use highly purified diosmin before and after procedures. We use in therapeutic cycles. Therapeutic cycles is 3 months medical treatment and 1 month not medication. 1 tablet daily we use, and we saw that it's very good compliance. The improvement of symptoms is very rapid and affordable price, easily accessible to the patient. In conclusion, we recommend diosmin 600 milligram, 1 tablet daily as background medication in chronic venous disease, regardless of the evolutionary stage of the disease, as soon as possible. Since the C0 stage. Thank you for your attention and thank you for your participation. Thank you.
Thank you, Professor Olariu. Very nice and interesting presentation. I forget to mention we have also colleagues from Macedonia as well. And I'm inviting all of you to send your questions in the chat, so I will be able to read them to our experts. And while we are waiting for some questions from you, from your side, and we can maybe see the results of the question, of the answer of the question that we just ask you to answer. And in the meantime, I would like to ask Professor Olariu, in your Victor Babes Institute, what is your strategy for post-operative therapy in patients that you treat with any type of intervention? What is your protocol for post-operative therapy?
In post-operative therapy, we use heparin as prophylaxis of thrombophlebitis, and generally use this fractionated micronized heparin, and also for post-operative in venous patients, we use elastic stockings mandatory.
How long do you use elastic stockings, and do you use any venotonic drugs?
We use venotonic drugs, as I said, in therapeutic cycle. In venous patients, 3 months treatment, 1 month pause. 3 month treatment, 1 month without medication. Elastic stockings after venous procedures, we use 2 months, but without glue. In glue, we don't use elastic stockings. It's not recommended.
Thank you. Any questions or comments from our panel, from our speakers? Do you have any questions from Professor Olariu? If not, I have there is a question in the chat. Which laser do you prefer?
Yes.
PDL or ND?
Sorry?
Which laser do you prefer? There is a question in the chat.
Yes. Radial fiber 1470, but I use from 8 years cryostripping, because I love this technique. It's very good, and no repermeabilization of the veins, and cosmetic, it's very good, and I like this. But if I use laser, then I use radial fiber 4070.
And do you use radio frequency with sclerotherapy? Do you combine this?
I don't use so much radio frequency because radio frequency laser is for private practice in hospitals, in university hospital. It's very difficult to achieve fibers, or the costs are very.
I can imagine. And what is the now situation with COVID crisis? Do you operate less patients with venous disease? And is in this COVID situation now medical or conservative therapy maybe a good ally in our practice?
Of course, in this period, we don't operate so many patients, and for venous disease, we use the private practice, because in the hospital it's very difficult because of the patient infected with COVID.
Okay, thank you very much.
Thank you.
We are now inviting Professor Petrov to share his screen. And while we are waiting, I would like us two technicians to give us an answer of your, how did you answer the question? Can we see the results? Can we see it before Professor Petrov starts? In this webinar, we have about 4,000 registrations from all over the region, but also we have about 700 registrations from Brazil, which is thanks to Professor Steinbruch, of course. If we don't have still results, we can continue with Professor Petrov, and then we can see the results after his talk. Professor Petrov, please.
Dear Professor Končar, dear participants in this very interesting and popular meeting, webinar, I'm very glad to be invited to participate, of course. I will speak this evening about the combination of topical and oral treatment of chronic venous disease. This is my disclosure. And I think that we know about pure diosmin 600 milligrams since 15 years, in fact, more than 15 years, since we heard the word pure diosmin 600. And in the beginning, it was curiosity. Is it something totally new and effective one, or just a new medicine that will expire like many others? The answer came very soon, and this was a hit, very balanced and practical for intake, with excellent effectiveness and very good tolerability. Patients also liked it very much. The cost and effectiveness seem to be calculated perfectly. In the market, there are a lot of competitive fishes, as you know, but common sense and practice rejected most of them. The success of pure diosmin 600 milligrams in Bulgaria is based on the fact that both doctors and patients are happy to use it in everyday practice. The way of introduction to Bulgarian market was also important, very precise and balanced, with no exaggeration or superiority presentation. And once it came into practice in pharmacies, it became a popular item. I think that the name of every medicine is something like the name of a man. They say the character of the person is 10% depending on the name. People here like the name of the product. It sounds very good and is remembered easily. Patients also are eager to find new medicines, and they always look for another option. I have a female patient who keeps visiting many pharmacies, and everywhere her question is, do you have something new? It sounds funny, but it is true. The phlebotomics themselves are a very special item because they are not life-saving medicines. And people are quite prone to make changes and experiments with different products, especially advertised by TV or relatives. The interesting fact about pure diosmina 600 milligrams is that very little patient discarded for anything else. Once a patient has started taking it, is love forever, like men love their favorite football team and women their children. And I must say that pure diosmina 600 milligrams is supporting each stage of chronic venous disease. Every tablet has three benefits. The first is relief of chronic venous insufficiency symptoms. This is a pain reduction, improvement and disappearance of heaviness in legs, which is the most common symptom in 3 of every 4 patients, and edema feeling in 7 of 10 patients. And relief patients in their daily activity are 7 from 10 patients. Then comes the comfort of use. Simple posology. This is due to the optimal dose of diosmina. This is only 1 tablet daily. The easy intake and the very high compliance, 96%, and tolerance, 99%, are very famous for this medicine. Also, the quality of the product is proved by international presence for more than 40 years on the global market. It is 100% made in France, and it has 1 active ingredient. This is pure diosmina, and it doesn't contain any liquid. About its clinical implementation. In clinical practice, patients trust the specialist. This is for any reason an illness. It is based on the fact that specialists have more experience in scientific knowledge about the right and contemporary visions in the field of science and practice. In my clinic, we use pure diosmina 600 milligrams as a routine medicament for every venous disorders, and recommend it for a long-term therapy afterwards. When patients come for follow-up, they give us impressions about the effect, tolerability, price, side effects, etc. And as I said before, the balance of all these seems to be very good, and patients are satisfied. The comments and assessments of GPs are the same, and this also reflects in good marketing of the medicine. In order to make objective criteria for assessment of pure diosmina 600 milligrams effect, we use some methods in our practice. Subjective impressions of the patient according to the main venous symptoms: swelling, pain, restless legs. Every patient treated with reports for relief of these in different degrees, from full recovery, slight improvement. The swelling can be measured before and after treatment, and it proves to reduce the maximal circumference of the calf and paramalleolar region with more than 2 centimeters after 1 month treatment. Interesting is the combination of local and system treatment. A new stage in the development of venous treatment began when systemic and local treatment were combined. This came to practice with 2% diosmina cream gel local ointment, the first one with diosmina from all these that we know up to now. It helps to relieve the feeling of heaviness and fatigue in the legs. Menthol provides cooling sensation. It helps to reduce the discomfort in the legs. It has very quick absorption. It doesn't stick or leave any stains on the body. Some effects are very interesting about this 2% diosmina cream gel. It is anti-inflammatory and antioxidant effects. It is connected with decrease of the number of dilated blood capillaries, which is very interesting, and the mean area of dilated blood capillaries. It has IL-8 excretion, and significant antioxidant properties. It decreases the number of cyclobutane pyrimidine dimers and cells and the level of hydroperoxide. And all these data come from ex vivo studies. The combination of local and system treatment, although very fresh, proved to be effective in several groups of patients. Post-thrombotic syndrome, this is a very common group of patients, and we found out that the maximal circumference of the cuff of our patients in paramalleolar region is reduced with more than 3 centimeters, which is better than using tablets alone. The combined treatment is very good. Another item is superficial varico or thrombophlebitis, especially post-prostatectomy. We have observed quick and very good relief of clinical symptoms, redness, tenderness, pain, and swelling of the leg after application of diosmina 600 milligrams peros combined with local treatment with cream gel. This is especially important in patients who underwent prostatectomy. On the second post-operative day, their symptoms start to subside and the reduction in swelling and redness in the perivein tissues are observed. Also, very good relief appears in patients with not complicated varicose veins in stages 2, 3, and 4 by SIAP classification. Patients report better quality of life and reduction of pain, swelling, and tension in venous structures of the legs, veins, and capillaries. As a whole, the combination of local and systemic treatment is reported to be more effective than the single use of these two. In my opinion, in the future, we shall have more information, more clinical trials, more indications for use of these combined treatments. And I thank you very much for your attention. And these are the references that we use to make our presentation. Thank you very much.
Thank you, Professor Petrov. Thank you very much. We have, I just have the information, we have 5,200 participants that are listening to us from 20 countries. This is a really enormous number of attendees. Thank you all for joining us. And thank you, Agency Miros, for technically and organizationally organizing everything. And I think organization is very good. So we have questions also in the chat. And I would like to ask you, Professor Petrov, how long do you recommend medical therapy? And what is the situation for pregnant women? Do you advise also therapy in pregnancy? And when would you start pregnancy therapy in pregnancy?
Thank you very much for this question. I think this is a new idea of implementing the treatment with phlebotomics nowadays, because as you very well know, a lot of persons, even without any venous disease, after a whole day work, especially in upright position, they have at least the first stage of chronic venous insufficiency. And this is especially interesting during the hot summer months, because in the summer, from these warm days, the veins are, as you know, in practice, they are very, very dilated, and we have tenderness, we have some swelling, we have a lot of other symptoms coming from these patients. So I think that during the whole summer, we should use some kind of phlebotomy, either local treatment or with tablets in order to protect the veins of the patient. Not only these healthy persons, but especially these that have some chronic venous insufficiency.
Yeah, can we see again the results of our voting at the beginning? And I want to ask you, what is your experience in topical therapy in early stages? Do you recommend it? And
Yes, I
do you have
will
experience?
recommend, because this is a very interesting new issue, since this local treatment is the first time, as I know, containing diosmina. And the combination, as I said in my presentation, proves to be very, very quick for absorption and for a reduction of all clinical symptoms of tenderness, of swelling, of restless legs, etc. So, as you asked in your former question, I also give these medicaments in the last trimester of pregnancy and in breastfeeding mothers, because I think that the diosmin, pure diosmin 600 milligrams is a very pure product. It does not contain any other substances inside, and it doesn't harm the patient or the baby or the mother, and it can be used, I think, quite very nicely in these patients.
Okay, thank you. We are going to our next talk, and I'm inviting Professor Steinbruch from Sao Paulo to share his screen and share with us his experience and his talk. Thank you, Professor Steinbruch, once again for joining us from so distance. And please, the floor is yours, or screen is yours.
Thank you. Good evening, good morning, good afternoon. We are wide world. I'm Professor Marcio Steinbruch, vascular surgeon with emphasis on phlebology. I have board certification in vascular surgery, effective member of Brazilian Society of Angiology and Vascular Surgery, head of the vascular diseases section of the post-graduation in clinical immunology at the Medical Postgraduate Institute Carlos Chagas, and member of vascular clinic in Albert Einstein Hospital, São Paulo, Brazil. I have no potential conflict of interest to report. I will talk about studies that are based on the use of pure diosmin at a dose of 600 milligrams per tablet. First, let's understand a little about the pure diosmin. From the citrus peel, specifically the orange, hesperidin is extracted, which through the hydrogenation reaction results in diosmin with hesperidin remnants. Through purification reaction, pure diosmin is obtained. Just a second, please. Okay. Several authors have conducted clinical studies on the use of pure diosmin in chronic venous insufficiency. And these are what we are going to expose in this presentation. First, I would like to thank Inoterra Laboratory, Yelena Koyitz, and Violaine Jabour, who have given me the honor of being here today, and thank again for the opportunity to participate in the study that I'm going to present now. We studied the non-inferiority of 600 milligrams pure diosmin compared to the use of 900 milligrams micronized diosmin plus 100 milligrams hesperidin in chronic venous insufficiency. This is the first study to compare pure diosmin at a dosage of 600 milligrams with the micronized purified flavonoid fraction of 1000 milligrams, both administered in the form of a daily tablet for 6 months. The study period for both groups followed the indication of minimum treatment duration in the description of the characteristics of the Flon 1000, which is in the Brazilian market. Sorry. Okay. The study period, Brazilian. This is a prospective, single-blind, parallel, randomized study with a total duration of 6 months for the patient. There were 4 visits, month 0, 2, 4, and 6, and controlled by phone calls by the researcher in month 1, 3, and 5. The study's main objective was to evaluate the clinical non-inferiority of pure diosmin 600 milligrams taken once a day compared to micronized diosmin 900 milligrams plus Experidine 100 milligrams from the reference brand, also taken in the same way. The primary outcome was a 50% reduction in the intensity of lower limb symptoms on the visual analog scale. Secondary objectives included the comparison between both for oral acceptability, tolerability, global patient satisfaction, and overall physician satisfaction. This study had the participation of some Brazilian university centers. University Center Serra dos Órgãos, Rio de Janeiro Federal University, Fluminense Federal University, Santa Casa, and Rio de Janeiro Estadual University. And the following doctors participated in this work: Marcio Steinbruch, me, Carlos Nunes, Romualdo Gama, Renato Kaufmann, Gustavo Gama, Mendel Surmacher Neto, Rafael Nigri, Natasha Citrimbaum, Lissa Brauer Oliveira, Isabelle Bertenat, François Verrier, and Mauro Geller. 120 patients over 18 years old, non-pregnant, were included with symptomatic CVD of the lower limbs, CEAP grade from 0 to 3, and symptoms of 20 to 60 millimeters on a visual analog scale of 100 millimeters. The visual analog scale globally assessed the most symptomatic leg with the following symptoms: heavy legs, painful legs, tired legs, swelling and/or tension in the legs. Visual analog scale was filled out by the patients themselves. We also classified oral acceptability. Swallowing was assessed by a visual analog scale of 100 millimeters, rated by the patient with 0, very easy to swallow, up to 100 millimeters, very difficult to swallow. As we had 6 dropouts in the middle of the treatment, the number was reduced to 114 patients with a mean age of 44.4 years, who were randomly divided into 2 groups of 57, where 90.4% of them were female. Symptoms improved in both groups with mean changes adjusted on the visual analog scale of minus 24.9 in the pure diosmin group and minus 22.8 millimeters in the combined group, corresponding to about a 50% reduction in the intensity of baseline symptoms. The reduction in symptoms was more pronounced in the pure diosmin group in the first 4 months of treatment, being the second month during the first evaluation the most significant one. The difference between the groups was minus 2.1 millimeters for a non-inferiority margin set at 20 millimeters. Therefore, non-inferiority was demonstrated. The difficulty in swallowing the tablets was significantly less in the pure diosmin group compared to the other group, 9.4 millimeters and 54.7 millimeters respectively at 6 months. The general safety of the two drugs was very good. In conclusion, it has been proven that pure 600 milligrams diosmin is not less effective than micronized diosmin 900 milligrams plus asperidine 100 milligrams, with a marked reduction in symptoms throughout the study being significant in the second month. It's also associated with greater ease in swallowing the tablets. The acceptance of the pure diosmin tablet was much higher. The researchers' overall satisfaction was good or very good, comparable for both drugs, 79% in the pure diosmin group and 76.8% in the other group taken for 6 months. This suggests that 600 milligrams is the dose of pure diosmin sufficient to relieve venous symptoms. These general results reinforce that the use of pure diosmin at a dose of 600 milligrams once a day is equally effective, being easier to swallow compared to the tablet containing the micronized form of diosmin combined with asperidine. Thank you very much.
Thank you very much, Professor Steinbruch. We can see the results of our response of our attendees. As you can see, 30% of them are treating with venotonics and medical compression therapy at the stage C1. So what were the symptoms of patients in your study, in the study that you just reported, the predominant symptoms?
Okay. The most common symptoms in our study were painful legs, tired legs, and swelling in the legs. Although we had the other symptoms, but the most common was these 3 symptoms. Were these 3 symptoms?
Yes, thank you. And did you see any side effects? And did you register any side effects from this therapy?
Yes, but they are very secure. The safety is very good. One severe adverse event, diarrhea, was reported in the pure diosmin group. In our study, we heard all reports of adverse events in both groups, whether or not they are related to treatment. The most frequent adverse events were nausea, dyspepsia, diarrhea, headache, and vertigo. There were 2 patients in the pure diosmin group and 1 patient in the other group with at least 1 adverse event that led to treatment discontinuation. These adverse events were palpitation, abdominal pain, diarrhea, and dyspepsia in the diosmin group, and vertigo and weight decrease in the other group.
Okay, thank you very much. We have also a question in the chat. What do you think about B12, vitamin B12 deficiency? Can it be linked to other, let's say, symptoms that are similar to chronic venous disease symptom? Do you have experience in vitamin B12 deficiency?
In CVD, we don't have an experience with vitamin B12, but maybe vitamin C has influence over the capillary. Sorry, my English is not good.
No problem, no problem. Okay, we understood.
Yes,
okay,
yes.
okay.
We had seen influence of vitamin C over the capillary circulation.
Okay, thank you very much. We have another question. Do you have experience with pelvic congestion syndrome and the medical therapy in these patients?
If I have
experience in pelvic congestion syndrome.
In my own experience, I treated some patients with pelvic varices, varicose veins in pelvic, and what? And I had a good experience with the use of pure diosmin in the symptoms.
Okay, thank you very much for your talk and for answering our questions. And we are going for the next speaker, Professor Dragan Milic, President of Serbian College of Phlebology. Professor Milic, please, we are looking forward for your talk.
Thank you so much, Igor, and I wish to thank Inotech company for organizing such a wonderful webinar. Well, as a cardiovascular surgeon, probably you are waiting for some kind of presentation about the operation. And this is going to be something completely atypical because I'm trying to convince you that compression treatment is still the cornerstone in the treatment of the venous disorders, and especially in the end stage of the chronic venous insufficiency. This is my conflict of interest disclosure. And when we speak about venous disease and chronic venous insufficiency, we know that this is a common problem worldwide. First, annunciation about the venous disorders goes to Hippocrates. And Hippocrates was really the first scientist, the first physician who used some materials for compression treatment. We know this SIP classification very well, and it is the simplest way to, let's say, focus on the C class of the venous disorders, and according to these classes, to make a treatment modality for the patients. Other classes moves up, like class 5, class 6. These are the most difficult stages of disease that really needs very, very complex treatment. The earlier presentations were related to lower classes of the chronic venous insufficiency, and I will speak about this end-stage disease. When we speak about the frequency and the epidemiology study, they're showing in the bone vein study, for example, we know that about 60% of entire population have some kind of venous disorders. And it is very interesting that when we speak about the end stages diseases, C4, C5, and C6, about 5% of entire population have this stage of diseases. And of course, our primary goal should be to prevent these patients with the C1, C2 class to move to the higher levels of C class classification. And as the population grow older now worldwide, we have more pronounced problem with the venous disorders. The older the population, the more pronounced problem with venous disorders are. And it is really problem everywhere. It is problem in the Western countries, it is problem in the eastern part of the world, it is problem everywhere, and it is gaining more and more now popularity for the treatment, and it costs really, really much for the healthcare system budgets everywhere, including the Western European countries. When we speak about the venous disorders, everything really comes to the physiology, and it is very, very easy to understand how the venous disorders develop. When we speak about pathophysiology, there are basically two processes. One is valve incompetence and another is venous obstruction. However, both of these processes are leading to ambulatory venous hypertension, which is the primary problem for the treatment of the venous disorders. And when we speak also about especially venous ulcers, the end-stage diseases, I like to define them as the two types of the venous ulcers, the primary venous ulcers and the secondary type of ulcers. When we speak about the successful treatment with surgery, with foam ferrotherapy, laser treatment, when we speak about diosmine drugs and so on, it is usually related to the primary venous ulcers. But when we speak about the secondary venous ulcers, the treatment is much more difficult. And nowadays we have more and more patients that are coming with this second phase of secondary venous ulcers. There are many now treatments, and I like to say that maybe we're not thinking much about the venous obstruction. There are data now in the scientific journals, and especially Professor Peter Neglen and Seshadi Raju published many papers on this topic, saying that maybe venous obstruction is much more present than we see it. So they're suggesting that we should use investigating the veins above the inguinal ligament in order to find any possible venous obstruction. And we can see this type of ulcers that we can see in Serbia, in the Balkans, and I like to define these ulcers as Balkan ulcers. At one point, I suggested to our friends to make new classifications with C6b, calling for the venous ulcers from the Balkan region. So when we speak about etiology, it all comes to the macro and micro circulation. But in its essence, the main thing that happens is inflammatory disease. So when we have this valve damage, when we have vein wall remodeling, capillary leakage, and capillary damage that leads to skin changes, everything really is leading to the elevation of ambulatory venous hypertension, which leads finally to the breakdown of the skin and the presence of the venous ulcers. When we speak about pathophysiology, as I said, there are two main things. There are insufficiency that we can treat very successfully, laser, radiofrequency, sclerotherapy, surgery, whatsoever, and we can treat this condition. However, when we have this insufficiency, it leads to the microcirculatory changes, which always have in their essence inflammation. Inflammation leads to the formation of the venous ulcers. So, in essence, leukocyte-endothelium interaction has and plays a key role in primary chronic venous diseases. And as I said, it is chronic inflammatory process. When we speak about treatment, of course, the starting point is always to correct underlying venous disorder. And we have so many treatment modalities, laser, radiofrequency, reflux. I think that all are really good. It comes to the preference of the surgeon. But however, the mainstay of the therapy for this is good compression. Without good compression, you cannot have a successful treatment of the most difficult end-stage patients with chronic venous diseases. So what happens with compression? Compression basically, when you apply external pressure on the calf muscle, it raises interstitial pressure, which leads to improved venous return and lowers the venous hypertension. So that is the beauty. It's very, very simple. And we have tons of papers and data showing the efficacy of compression treatment in the treatment of the most difficult venous disorders. For me, this is the most important paper that I ever read about compression treatment. And this is the paper that was published by Professor Hugo Patch. And this was really ingenious paper. He did a very simple experiment, and he was trying to find what is the level of external pressure that leads to the occlusion of the veins. in supine position, in the standing position, and in the lying position. And basically, he found that in the lying position, 20 to 25 millimeters of mercury is needed to occlude the veins, 50 to 60 millimeters needed in sitting position, and 70 millimeters of mercury, the pressure, is needed to occlude the veins in standing position. So these are the markers that we are leading. Usually when we speak about compression, we always speak 15, 20, 25 millimeters of mercury, which is insufficient to make good treatment for the most difficult patients. These data are showing the target external pressure that we want to achieve in order to make a successful treatment. This is crazy, and we have so many different classes, class 1, class 2, class 3, class 4, you know, British, German, French, US, and it's chaotic. And I hope that one day phlebological societies in the world will make a consensus statement, you know, finding one compression. Why is this all about different stages? Because, you know, in France, in Western European countries, the patients are prone only for the lower class of compression. So these countries do not have high class of compression. Their patients cannot stand. They don't have good compliance. On the other hand, in some countries, like in the Balkans country, I don't know, the people are maybe tougher, but they can comply with much higher compression that leads to the treatment of the most difficult venous disorders. When we speak about diosmin, it is well known that it really helps, especially in diminishing some kind of symptoms. But it is impossible to say that any kind of drug can lead to the treatment of the most difficult stages like venous ulcers. There are some papers suggesting that diosmin can lead to healing of the venous ulcer, and I think that this is completely wrong. It is impossible to heal any venous ulcer without compression treatment. Maybe you will have better comfort for the patients, but if you do it without compression, no way you are going to make any success in the treatment. So I will tell you about our method that we use for the treatment of our patients. This is our study that we performed. We used a beautiful tubulcus elastic stocking, very simple tubular device. It is produced by the Inotec company. And in order to achieve a higher compression interstitial pressure, we add one elastic bandage over tubulcus. And on the other hand, we had the group that were using only elastic bandages. And the patients were wearing all this compression treatment all day and all night for the time of the treatment. If you have very large ulcers, the patients obviously need to wear these compression stockings and these compression systems for very, very long time, sometimes 2-3 years long, in order to make a success. So this was our initial study that we performed 15 years ago, and we compared 72 and 66 patients in these groups that used tubular device with higher pressure and patients who used only bandages with lower pressure. And the results were compared to the patients who had difficult venous ulcer or complex venous ulcers, the ulcers that had 70 or 60 square centimeters in surface. So they were very, very, very large. And our results showed that we had 93% of people who were wearing these strong compression devices, healing rate with venous ulcers, and only 50% with elastic bandages of lower compression statement. And the days for the healing were also lower in this tubular device group compared to the bandages. In order to convince doctors that compression treatment is successful, I would like you to show you the patients that we have treated with difficult ulcers that were healed after treatment. This venous ulcer was treated just for 23 days, and it completely healed in 28 days. Patient was never treated with compression treatment before, and she had stripping, she had all different types of surgery, which were unfortunately unsuccessful. This is also the treatment of the male patient, and in 3 months' time, the ulcer healed. lateral side venous ulcer are much difficult to treat, but then again, using these compression devices and elastic stockings, we can really promote and we can really make the difference in healing these patients. You can see these terrible venous ulcers, and if somebody receives this patient at the clinic and ambulance, they say it's ridiculous, you cannot do anything. But no, after 280 days, you can make a tremendous success with using compression treatment. And these are also pictures of our patients with bilateral venous ulcers, the patients who were treated with these strong compression devices. And you can see how skin progressively improves and covers the damage the skin has. This patient was typical because he had rheumatoid arthritis, and he was really very difficult to treat because he was immobile, he couldn't walk. But then again, and even him at the 90 days mark, he healed. And you can see we have about almost 3,000 patients who were treated at our clinic. And you can see that this compression really works. And you can see another very difficult and large venous ulcer that was healed with these strong compression systems. I like these pictures because picture can paint 1,000 words. And if this is not convincing enough, I don't know what else is. So compression treatment still is the method of choice, not just for the venous ulcers, but for the lymphedema. This woman never was treated with compression. She received all different types of therapy. She had lymphedema. And look, the results after 7 days of treatment. It's just unbelievable that nobody used compression treatment for this disorder. So compression is really effective, and especially in end-stage diseases, we should think about compression treatment as the cornerstone of the therapy. As I said, we had almost 3,000 patients who were treated from all over the Balkans at our clinic. And I must say that, since 2006, we gave more than 100 presentations worldwide. This was the first presentation we gave in 2006 at the American College of Pathology. Just a couple of months later, we gave presentation at the American Venous Forum meeting. This was published in Journal of Vascular Surgery. So who wants to read a little bit more about work, you can find it in Journal of Vascular Surgery. What is very important when we speak about chronic venous disorders, they're really chronic. So I think this is the only study that is now present in the world that has a follow-up of 10 years after the successful treatment of the patients with venous ulcers. All these patients took off compression stockings after 2 years. In the next 10 years follow-up, 98% of them received a recurrence. So this is really a chronic disease. Very important, the higher the pressure, the better results, definitely. If we have higher pressures, then we will have even the lower recurrence. After venous ulcers healed, we need higher compression, 30-40 millimeters of mercury, lifelong compression in order to prevent these recurrences. And really, I had great pleasure during my life to meet people like J.J. Bergam in the United States, the gurus of phlebology, Professor Bo Eckloff and Professor Hugo Patch, who gave us the tools we can measure and we can compare. These are really giants, and I'm really so proud to know all of them. Peter Neglen, the guy who first performed venous stenting of the veins above the venous ligament, Peter Glowicki at the Mayo Clinic. And I'm proud to say that in 2007, we have founded Balkan Venous Forum in order to promote, the venous disorders in order to say that, the pandemic did really show that there is no borders. If the viruses, the venous disorders and everything, they don't recognize borders, they just pass by. So I think that we should unite together in order to educate people for the right way of the treatment, depending on the classification of the venous disorders. Hopefully I wasn't too boring, and I wish to thank you all for your attention.
Thank you, Professor Milic. It was not boring at all, and you have compliments in the chat as well. And there are a lot of questions coming, so I will just go on the questions. Since you showed the recurrence rate in your 10-year follow-up, what would be your suggestion? How long would you advise compression therapy after healing the ulcers?
Lifelong.
Lifelong.
Okay.
And what would
No
be
doubt
the...
about it. No doubt about it, Igor. It's lifelong. It is the problem that with recur, you know, the patients usually don't come back to doctors. That's the problem. We don't have this follow-up on the regular basis. We all know that these patients are, you know, very, very difficult to track. And our results really show that more than 90%, 98% of the patients will have recurrence in the 10-year follow-up period, unfortunately. So we are suggesting the lifelong compression as a mandatory thing. The higher compression, the better.
And do you change the compression once the ulcer is healed, or you leave the compression, the pressure the same?
We used to do this, and after this study that we finished, it is not published yet, but we hopefully think we are going to publish it in the next couple of months. Our suggestion is to have 2 bulbous elastic stockings as the primary measure. 2 bulbous elastic stockings gives 30 to 40 millimeters of mercury. And we think that the patients who had venous ulcers need this type of pressure lifelong in order to prevent venous ulcers. Unfortunately, even 30 to 40 millimeters of mercury will not prevent recurrence again. But then you have to add this elastic bandage one more, and you need to elevate the compression in order to stop these recurrences.
And do you advise any medical therapy alongside the compression?
We always recommend medical therapy because it gives a little bit of more comfort to our patients. But you know, without compression, there is no success.
Yeah, I'm reading the questions. I'm sorry. And what about the patients with peripheral occlusive disease? Is there any, you know, advice for our attendees, for our colleagues? Do you have any exclusion if patient has occlusive disease, arterial occlusive disease?
When we have peripheral occlusive disease, first thing, this is the patients that are most difficult to treat. But if it is possible to make any kind of bypass, we usually do this. So, and we leave it 3 months after the bypass procedure in order to see what is going to happen with the venous ulcer. And if it persists further on, then we apply compression treatment. If it is inoperable patient, then we use compression, but with the lower compression, maybe 20, 25 millimeters. And we think that our patients have benefit with this low compression.
And how do you fight with compliance of patients to compression therapy?
Well, really, we don't have this kind of problem with patients who have these massive ulcers. You know, we have problem with patients who are stage C2, and we have to convince him, please, you know, you should wear compression stockings. And he says, you know, what the hell, nothing is going to happen, so I'm not going to use compression. These are the difficult patients. On the other hand, when you have patients with venous ulcers, for example, we had a patient who had active venous ulcer for 42 years. You know, we don't need to convince him. After, when the ulcer is healed, when we say to them, you can go to the lower compression, they say, no. We feel much safer with its high compression because he see the results. If he had ulcer for 6-7 years, he didn't have normal life. And afterwards, when the ulcer healed, you don't need to convince him. The problem is maybe first 10 or 15 days, you know, until they see that they have less pain, that the ulcer is starting to get smaller and smaller. And when they see all these things happening, then we have no problem in convincing them.
Okay, thank you. And what level of bandage you advise for C2 or C3 stage of the disease? What kind of
low, class 1 or class 2, that is good enough in our opinion. And the most important thing is for the patients to stay active. if they have this sedentary way of life, sitting by the table like we do now and playing with the computer, or if we start, this is something that we should, educate our patients that they should be mobile, they should be active. Also, we have one nice paper speaking about the risks of venous ulcers. One of the highest risks for venous ulcers was immobility. The patients who are not moving much, they are developing easier venous ulcers that are growing on the large scale, really.
We have maybe 1 or 2 minutes if anyone from the panel wants to comment or make a question or make any comment about his experience in elastic stockings. Professor Petrov, Olariu, Professor Steinbruch.
In sclerotherapy, my opinion, the elastic stockings should be used day and night, 3 weeks minimum.
Okay, thank you.
I agree completely. When we do sclerotherapy, we suggest our patients at least 4 weeks and preferably 6 weeks. The higher compression, again, after sclerotherapy, the higher compression, the longer compression, the better results and the lower recurrence rate for varicose veins.
Professor Petrov, what is your experience in C1 or C2 or C0? Do you advise elastic stockings, and what level of pressure do you advise?
Thank you very much. I think that in these stages, it should be depending on the complaints of the patient. If the patient has anything to do with the tenderness, with some swelling or restless legs, he should use, of course, elastic stockings, but not for everyone, because especially in the summer when the weather is hot, sometimes you cannot use stockings according to my...
So you advise relying on medical therapy actually in these
medical
stages.
Therapy, and I want to congratulate once again Professor Dragan Milic. I think he made a very good devoted presentation. I think he is the king of compression here in the book.
Thank you so much.
Congratulations.
Thank you so much.
I just
want to add a thing about medication, and I strongly agree with Dr. Petrov about the patients with the restless leg syndrome, for example. And I also think that very often we don't need compression in these patients. But in our clinical practice, the best possible possibility for the treatment of these patients is diosmin, where I often use diosmin as differential diagnosis. When patients come to us and they say, I have aches in my legs, I have a compression, I don't feel well, we give them diosmin for 15 days. In 80% of cases, we have solved the symptoms. And then we definitely know that that comes from the venous disorders. Maybe in 10-20% we don't have any results, and then we can find that maybe it's a problem with the spine or something different. So I think that the most important part for the medication, for the Phlebodia, for the diosmin drug, is definitely the patients who have the symptomatic patients, and they have really, really tremendous results when we use diosmin for their treatment.
Thank you very much. Professor Steinbruch, any comments from your side?
In my experience, it depends on the complaint of the patient. If he has pain, swelling, I start using compressed stocking and medicine, diosmin. And I have good experience. The pain improved. In near 15 days, we have we experience results, good results.
Okay, thank you very much. Thank you all the speakers. We are going to the second part of our program now, which includes introduction of our colleagues in the region. So I will invite several colleagues from different cities, different countries in the region, and we will have some of their input and some of their experience in chronic venous disease. So our first guest is Dr. Radmil Maric from Foča. Dr. Maric, do you hear us? He is already in the room. He is muted. Dr. Maric, if you can unmute.
Hello, Igor.
Hello, Radmilo. Zdravo, Radmilo. I hope you are well. So I hope you enjoyed the webinar. And can you tell us something from your experience in Foča? And what is your opinion on the combination of different types of non-surgical treatment of chronic venous disease?
Hello, I'm Radmil Maric, vascular surgeon at Foča University Hospital, Republic of Srpska, Bosnia and Herzegovina. Combination of compression, oral and topical product is the best solution because of their synergistic effect. For the last 15 years in treatment chronic venous disease, I have been using compression stocking, tuberculosis, and diosmin preparation, Flebodia, product of pharmaceutical company Inotech International, and I'm very satisfied with achieved results.
Okay, thank you very much, Dr. Maric. It was nice to hear you, and I hope we will see in the future in face-to-face, and we can discuss more about this topic. It's been a while since you've been in our clinic in your subspecialty education, more than 15 years ago, as I think. So I'm inviting I'm inviting another guest, Dr. Alen Hajdarević from Tuzla. Dr. Hajdarević, I hope you can hear us. He is entering the room.
Yes.
Dr. Radmil Maric is still talking, but yeah, now not. Okay, thank you. And Dr. Hajdarević, can you hear us?
Yes, I can hear you. Good afternoon, Professor Končar and other professors and organizers and all of participants.
Thank you very much, and I hope you enjoyed the first part of the webinar, and thank you for joining here with us from Tuzla. It's a great opportunity to have all of us here. And can you tell us what is... Yes.
Thank you. I agree to all of you from Tuzla. I would like to congratulate the organizers and on an exceptional webinar and really useful lectures, presentations, and results from the professors and from all my sides.
Yeah, I would like to ask you, how do you choose your preferable venotonics? Do you think they're all the same, or what is your, preferable choice in terms of dosage or way? How do you apply it, or how do you choose it?
Yeah, we are choosing in our daily practice usually Flebodia 600 milligrams in our topical therapy and treatment our patients, and I don't think so. We have many various and different products on the market, but I don't think so. That's the same thing. I always recommend to my patients drug rather than food supplements, and original drug rather than generic due to more clinical proofs behind it. I think so that we have many supplements that contains sufficient dosage of active substance, so I don't include them in the treatment of my patients. My choice is always Flebodia 600 milligrams with another topical therapy like elastic compressive stockings, aspirin 2, and so.
Yeah, thank you very much. You heard probably the talk of Professor Milic and the comments of elastic stocking therapy.
Yes.
Do you have problem with your patients about elastic stockings? Do they accept to wear it, and what is your experience?
Yeah, we have some kind of problems with patients and topical therapy with elastic compressive stockings, and that is not natural things for my patients, and that is very difficult to accept. The patients have a night time pain after recovering, and that's not, I said, that's not natural thing for the patients, and that's the real problem for us.
Yeah, I agree. Thank you for your comments, and regards to all our colleagues in Tuzla.
Thank you very much.
And we are now going to Skopje, to Mother Teresa Hospital. We have Professor Marian Boševski, cardiologist from Mother Teresa Hospital in Skopje. So I hope he will join us in a minute, and we can hear what is their experience and how they treat chronic venous disease. Dr. Boševski, are you here with us?
Okay, I'm here.
Yes.
Thank you, Professor Končar. Thank you, Inotech, for this extraordinary event, finding very useful as well. At this moment, I want to share some expertise from our vascular center. Our vascular center is a part of University Cardiology Clinic in Mother Teresa campus, servicing the whole internistic clinics and surgery clinics as well. The main point of our vascular laboratory is diagnosis and treating of different kinds of venous chronic, but also thromboembolic events. In this manner, I want to stress that diosmina is very useful, not only for improvement of quality of life in patients with post-thrombotic syndrome after episode of deep venous thrombosis, but also is very efficient in secondary prevention of another thrombotic events. We use diosmina in dose of 0.6 grams, especially in these patients with premature discontinuation of anticoagulation after the episode of deep venous thrombosis. In those patients with episode of deep venous thrombosis, where with ultrasound we found residual thrombosis and different stages of venous reflux even before symptoms onset. We found very useful this drug, and we stress that this is a drug of choice for secondary prevention of another episode of deep venous thrombosis, and also for improvement of symptoms in these patients.
Yeah, thank you very much. Do you combine it with some acetyl salicylate acid in these kind of patients?
If there is indication for another comorbidities, as a coronary artery disease, but when we are talking only in patients with venous thromboembolism, we do not use.
Okay, thank you very much, and send our regards to our colleagues in Mother Teresa Hospital in Skopje, to all the cardiologists, phlebologists, vascular surgeons in your team. And I hope you enjoy the webinar, and hope to see you again in face-to-face meetings somewhere in the Balkans, maybe by organization of the Balkans Venous Forum, as mentioned by Dr. Milic. And I'm inviting now Dr. Perica Maraš, vascular surgeon from Montenegro, from Podgorica. He's head of vascular surgery department in this clinical center of Montenegro. So, Dr. Maraš, I hope you're just going through this online world and coming to our room. In the meantime, if any of the panelists have any comments about comment maybe of Professor Boszewski about usage of diosmin after as a secondary prevention for thromboembolism. Do you have such experience in your practice? Dr. Marash? Dr. Marash, okay. So next, I'm inviting Dr. Gencian Tsatso, from vascular surgeon from Tirana. Can we invite him? Do we? Okay, he is entering the room now. I can see him in the chat. You're muted, just unmute.
Thank you.
Hello, welcome.
Hear me now. Hello, it was a very good conference. Thank you to all the panelists.
Thank you, and thank you for joining us. I would like to ask you, what is your experience and what is your strategy in patients with venous ulcers? How do you treat them, and what is your experience?
Okay, well, it's of course part of the practice every day, but I will divide those patients in two groups mainly. Those with young ulcers, who mostly are young people with superficial insufficiency, and they are rather simple to treat with some endovascular procedures or even surgery. And the bigger group, elderly patients with old ulcers, mostly because of post-thrombotic syndrome. And this is the group that, as you heard by Dr. Milic, is very difficult to treat. Well, normally the cornerstone for their treatment is bandaging and compression in general, even for me. I use non-elastic compression with bandages as when the ulcer is open, and above that, elastic stockings. And in the moment the ulcer heals, I will use only elastic stockings of the third class, or a tubular device like tuberculous, for example. That is my general strategy. So
you are actually following similar strategy as Dr. Milic presented, as I can understand.
I believe in compression. It's the best way to treat an old ulcer, at least.
Yeah, I'm glad to hear that you are doing the same. And do you have similar experience in terms of compliance of the patients? Because Dr. Milic said he has no problems in compliance. As you heard from Tuzla, they have sometimes problem with patients. And what is your experience?
There are always some difficult patients, but in general, I will agree with Dr. Milic. Patients with big ulcers, they don't complain much for their bandaging or compression with stockings. They are more compliant. Young patients with young ulcers, they are a little bit difficult to convince. But hopefully they are the kind of patients that can be treated with some endovascular strategy. So they need less compression for less time. So it's simpler for them.
Yeah, usually patients, when you give them elastic stockings, they say, do you have any drug? I mean, you give me just a sock, what is this? And it is good that we also have some drug therapy to combine, and for those who are not willing to wear elastic stockings and are still in the beginning of the initial stages, we have other conservative methods, which is good. Do you have any questions from our panel or any comments regarding the previous talks that you heard?
No, I was only wondering, but it's my opinion, about the first, I think, presentation. Dr. Olariu, he told us he was using low molecular weight heparins during all his operations. Well, I think that minor surgery like laser radiofrequency or steam, they really don't need anticoagulant treatment after the treatment. It's my opinion. I think it's discussable.
Yeah, thank you. I saw you said that in the panel in the chat, so I waited for you that you come here and you can ask your personally questions. So Dr. Olariu, do you have any comment about this?
Yes, you have right, but for more to be more sure, we use 5 days low molecular heparins because we had 1 or 2 deep venous thrombosis, and before this deep venous thrombosis, we didn't use this, but now, as a rule, we use 5 days low molecular heparins. And
okay, thank you. I'm also looking for other.
However.
Sorry? And I have a small comment about the venous ulcers. I think it's very important to interrupt the reflux, first step, because all or most of the venous ulcer appear by reflux perforant, and it's very important to interrupt this perforant, and normally compression and other measures.
Okay, thank you very much. I have information that Dr. Marash can join us. So thank you, Gencian. Thank you for your participation. Hope to see you also in somewhere face-to-face. And I'm inviting Dr. Marash, Perica Marash, vascular surgeon from Montenegro. He found a way to join us. Dr. Marash, hello.
Hello.
I hope you're well. And how is the situation in Podgorica?
Good evening. Good evening for Podgorica.
And what is, according to your opinion, main issue with the treatment of patients with chronic venous disease in your practice? What do you find, the highlight, the main thing?
Okay, thank you for your question. Sometimes the compliance of the patient is lower when they have to take pills several times a day. There are so many reasons for that. Either they forget or they already are taking too much pills per day, and this is battering. This is why I recommend drug which is taken only once per day, Flebolia.
Okay, thank you very much. I'm sure that patients in Montenegro are enjoying this one-time dosage, and say hello to all our colleagues in Podgorica Clinical Center. And I'm inviting finally, the last but not the least, Dr. Rudari from Pristina. Dr. Hairis Rudari, vascular surgeon, head of Department of Vascular Surgery in University Clinical Center, Pristina. Dr. Rudari. You are here with us. Okay, he is coming.
I would like to thank the company Note to enable me the participation in this event and for continuous cooperation. And I would like to thank the professor for the wonderful, very important lectures.
Thank you, Professor Rudari. And what is the situation in Pristina? How is the treatment of patients now during the COVID crisis? Do you have any, any impression to give us?
Yes, the safety of medicine is very important. We recommend venotonic that can be combined with acetyl salicylic acid, low molecular dose heparin, and this is most often Flebolia.
Thank you very much. Thank you for joining us. Actually, we have still a lot of attendees watching us. So any final comments from our panel speakers? Professor Olariu, do you have any final comment before we wrap up and we close this webinar?
Yes, was a great webinar. I congratulate you. And finally, in my opinion, the venous disease, it's an evolutive disease, and the treatment is very complex, and in this treatment, drugs, elastic stockings must to be all along. The minimal invasive procedures is one step, but the treatment must to be all along with elastic stockings and drugs.
Thank you very much. Professor Petrov, any final comments from your side?
Yes, I would like to thank you once again, because it was a very nice webinar. I think we began very clever after this one. And I would advise you to organize it annually, probably for all the Balkan countries, because we know each other what we are doing in our clinics. And this is very precious knowledge that we get from this webinar. Thank you once again.
Thank you. Professor Steinbruch, any last comments from your side?
I want to thank you, everybody, and congratulations for the organization. And only to end our speech, I don't use anticoagulation after surgeries, only if the patient is in a risk group. So I use. Thank you very much. Hope see you again in other meetings.
Yeah, thank you very much. Before we close, I would like to ask technicians, our very good technicians, and thank them, Agency Miros, to give to our attendees another question to answer. And while they're answering, I would just like to thank to all speakers for their wonderful talks, really talks of experts, really. I also enjoyed and learned a lot. We can say that we had some things to discuss, like anticoagulant therapy after surgical treatment. We saw that some patients, some physicians have problem with compliance with elastic stockings in the patients with the lower grade of chronic venous disease. And for venous ulcers, we saw that patients are better compliant. We saw that one daily dosage is as effective as 2 daily dosage, as patients are accepting it very well. So this is something that was also as a message from this very nice webinar. Of course, treatment early as possible, as we say in this slogan of this webinar, be smart and act early, which is probably the optimal thing for patients with chronic venous disease. These are all the messages that come from our colleagues, our experts, and let's see if our attendees maybe change their opinion about at which stage of chronic venous disease they would suggest initiation of venotonic and medical compression therapy. Can we see the results? Because at the beginning we have about 30% for C1 and maybe 27% for C2. Let's see how is the situation now after all these talks and after discussions that we have. We also had very nice interviews with our colleagues from region, and I thank them also all for joining us, and hopefully we will see somewhere in the face-to-face meeting, maybe end of this year or next year after the vaccination. Do we have a result? Okay, we still we have about almost 2,000 people watching still, which is really great success of this webinar. So we need 2,000 people to vote, and Okay, even more now. There is a difference after this talk. So more attendees switch from C2 to C1, I can notice. So this is, I think, the success of this webinar, and this is the message probably of this webinar, to start earlier with medical and compression therapy. So on behalf of the Serbian Society of Cardiovascular Surgery, on behalf of company Inotec, and I thank them for organizing this, and agency Miros. I wish you all a nice evening, and hopefully in November, Serbian Society will organize a big event, and hope to see you there maybe. Good night, good afternoon, or good morning, wherever you are. See you soon. Bye-bye.
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 Bye, good night.